Your passcode has been confirmed. If you need technical assistance during your call, press *0.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
Good afternoon, and welcome to the CDC's Hemoglobinopathy webinar series. I'm Shay Pope from the Division of Blood Disorders, and I'll be serving as today's moderator. As the conference leader, I have muted all the conference lines to eliminate background noise. After the presentation, we will allow questions, and you'll have to press *6 to individually unmute your line at that time. If you have a question, you can electronically raise your hand by accessing the Q&A tab on the menu bar of your webinar screen and click on the hand icon in the upper right corner. This will display your name to the moderator. I'll call on participants as their names are displayed, and you can raise your hand during the presentation, but we will wait to the discussion period to address those comments. Also, this session is being recorded. Today's topic is an overview of sickle cell disease in Angola. Dr. Russell Ware is the Marjorie Johnson Endowed Chair of Translational Hematology, Professor of Pediatrics at the University of Cincinnati, and Director of the Division of Hematology at Cincinnati Children's Hospital. He obtained his medical degree from Duke University, completed pediatrics residency training at Texas Children's Hospital, and his pediatric hematology oncology fellowship at Duke. Dr. Ware has been involved with clinical and translational research involving children with sickle cell disease for over 25 years and is the national PI on several multi-center clinical trials. He designed and launched the original newborn screening and treatment program for sickle cell anemia in Angola and is now conducting research trials to introduce hydroxyurea for children with sickle cell disease living in low-resource settings. We'll also be hearing from Dr. Patrick Mcgann, who's an assistant professor of pediatrics in the Division of Hematology at Cincinnati Children's Hospital. He obtained his medical degree from Tufts University, completed his training in pediatrics at Massachusetts General Hospital, and his fellowship in pediatric hematology oncology at both St. Jude Children's Research Hospital and Baylor College of Medicine, where he also obtained a master's degree in clinical investigation. Dr. Mcgann was a leader in the development of the newborn screening and treatment program for sickle cell anemia in Angola and lived in Angola permanently during much of the first 2 years of the program. His research interests now remain focused towards improving the diagnosis, care, and outcomes for children with sickle cell anemia across the world. So at this time, I'd like to turn the presentation over to Dr. Mcgann and Dr. Ware. If one or both of you could unmute your line by pressing *6, and you can begin addressing the audience.
Hello, this is Russell Ware. Can you hear me?
Yes, we can.
And this is Patrick Mcgann. So thank you very much for the opportunity to speak today. We're very grateful for this opportunity to talk about sickle cell disease activities in Angola. It's interesting to me to reflect back when this project first became a possibility about 4 years ago, and during the initial planning phases, and finally became a reality 2.5 to 3 years ago. Much work has happened, and I want to acknowledge the very important roles of Chevron Corporation and Baylor College of Medicine, where most of this work occurred while both I and Dr. Mcgann were affiliated with Baylor at that time. We're going to talk some about the newborn screening program, but also new additional activities, and we'll just move right on to the slides. So the overview of today's tandem talk is as follows. We're going to give you a brief description of sickle cell anemia in Africa. We're going to give you a description of child health and particularly of the children with sickle cell in the Republic of Angola. We will describe the pilot newborn screening program that was developed and launched in mid-2011. We'll talk about training and education programs that were a part of that newborn screening program, but also have expanded now to new regions and new parts of the country. Spend some time talking about hydroxyurea, the potential role of that to ameliorate the disease in Angola. And then finally, try to reflect on some of the lessons learned and discuss future directions. This graph was published some years ago by Solomon Ofori-Akwa and Kwaku Ohene-Frempong, and it provides a visual of the number of births per country in Africa. Now, they're the first to admit that these are just estimates, but it gives you a reference point, and we've drawn a red line where 10 to the third or 1,000 births per year would occur. You can see that a number of fairly small countries have under 1,000 births per year, where there are many countries that have over 1,000 and even over 10,000 births. We think that these numbers are underestimates, particularly at the lower end, and probably Uganda, Tanzania, Angola, DR Congo, and Nigeria have well over 10,000. In the case of Congo and Nigeria, 100,000 or so. Fred Peel has given us some nice estimates through his publications in the Lancet that describe estimates of the burden of sickle cell allele, the sickle allele, and has quantified over 230,000 infants are likely born each year with SS in sub-Saharan Africa. But as we probably all know on this call, there are few newborn screening programs and certainly no associated treatment programs that are widely available. And a little bit to our surprise, considering the prevalence of the disease, the sickle cell awareness by patients and especially healthcare providers is relatively low. And one of the reasons this is so important to address is that the mortality of hemoglobin SS and other forms of sickle cell is very high in early childhood. And as it relates to WHO and UN Millennium Development Goals, sickle cell contributes significantly to the under 5 mortality. Most of the people on this call are familiar with Millennium Development Goals set to reduce infant mortality to low levels, 1/3 of where they were in 1990 by 2015, and Dr. Mcgann will talk about the importance of sickle cell anemia as an under-recognized contributor to that under 5 mortality. So where are we worldwide? Well, this stamp is a reminder that in the United States and its territories that we screen universally for sickle cell anemia. But I want to start off with a few points here that universal screening occurs in the U.S., but we have fewer than 1% of the births in the world. And yet, despite that low amount of birth prevalence, screening for sickle cell in the U.S. is cost-effective, and this has been published by a couple of groups. And in the United States, although the sickle allele is not universally distributed across our population, sickle cell anemia is one of the most common newborn screening abnormalities, if not the most common, right up there with congenital hypothyroidism, probably 2,500 to 3,000 births per year. In European countries, which also collectively have fewer than 1% of the births globally each year, there are some countries that are adopting universal, but others use selected or targeted screening or do not screen at all. And of course, what's relevant here today is that newborn screening programs in Africa are virtually non-existent, although there are a few pilot programs. I'm sure you're aware of the seminal programs that were developed in Benin and Ghana. There are also some pilot programs in Congo, Liberia, Nigeria, Tanzania, and others. The WHO is perhaps a little slow to recognize the burden here, but published in 2010 a white paper describing a WHO initiative, a strategy for the African region. You can see highlighted the date is 2010, 100 years after the initial description in the medical literature. And two phrases are highlighted here, that current national policies and plans are inadequate, and the deaths from sickle cell complications occur mostly in children under 5 years. So what about Angola? So it's on the West Atlantic side of Central Africa, very large country, almost twice the size of the state of Texas, but it's only the 7th largest country in Africa, 17th by population. Its population is about 20 million. It's a Lusophone country, primary language Portuguese, and it had a brutal, extended civil war in the latter part of the 20th century, but emerged peacefully in 2002 and recently celebrated its 10-year anniversary for peace. And as part of the rebuilding of the country, has made a commitment to health care. So why focus on Angola today? Well, a unique combination of circumstances. As you know, some first ladies in Africa have targeted sickle cell as an important health initiative, and the first lady of Angola was one of those who recognized it as an important health priority. There's also a very strong presence of American and international business, including Chevron Corporation, and through that link with their corporate and social responsibility arm, we're able to come up with a plan for a sickle cell initiative in the Republic of Angola. And their initial contacts were with the Baylor College of Medicine and Texas Children's Hospital, and a really important three-way private-public academic partnership was made with the Ministry of Health in Angola, Chevron Corporation, and Baylor College of Medicine, and specifically the International AIDS Initiative there that led to this three-way partnership that led to the newborn screening program. So at this point, I'm going to turn the speaker over to Dr. Mcgann, who will describe some of the specifics of this program, and then I'll pick it up later and give some perspective.
I'm going to talk to you specifically about the child health and circumstances of Angola that we started with, what we've done to date, and what activities are planned for the future. So as this graph demonstrates, or this slide demonstrates, child health in Angola remains a large problem. The Civil War really devastated the entire healthcare system, particularly the healthcare realm. There's over 800,000 babies born each year, and a very high fertility rate with 5.3 babies born per woman. This high fertility rate is probably related to the high mortality rate that women have to have more babies to have surviving babies that reach adulthood. Angola is one of the highest under 5 mortality rates in the world. Nearly 16% of babies that are born won't reach the age of 5. As the graph on the right demonstrates, the frequency of the hemoglobin S allele. Angola is kind of in the middle. We don't really know, or when these graphs were put together, I think it's not very clear how high the burden is in Angola. There's likely some geographic distribution where there may be more disease in the north than the south, but there really wasn't any data prior to the last few years. Angola is not a poor country, as Russell mentioned. Chevron has a large presence, and the country is very rich in both oil and diamonds. This is a graph from the WHO. The triangles represent Angola, and the open circles represent other African nations, and they represent healthcare spending per capita. You see that before the war ended in 2002, Angola was below its neighboring countries in healthcare spending. But really, since the war ended, over the last 5 to 10 years, spending is really through the roof, where Angola is spending 2 or even 3 times more than most of its neighboring countries. If you juxtapose this graph on it, it's kind of discouraging. This is a similar graph. Angola is in the triangles, and neighboring countries are in the open circles. And Angola has always been above the average for Africa for child mortality. And due to basic interventions like vaccines, particularly, mortality is going down. But despite the very high spending, Angola is not really making any strides to improve their mortality in relation to their neighbors. So it's likely due to spending that's targeted at buildings and equipment and less so about building infrastructure and capacity with personnel. So Luanda, this is where we started. This is the capital and largest city in Angola, in the smallest province towards the north part of Angola on the coast. There's about 5 or 7 million people, depending on which estimates you use, that live there, a large majority of whom do not have access to water or electricity. Luanda is the home of the largest and only true pediatric hospital in the country, public pediatric hospital in the country, Hospital Pediatrico David Bernardino. In this clinic, this hospital, even before our arrival, had a very busy sickle cell clinic that I'll talk a little bit more about. Hospital Pediatrico David Bernardino, or HPDB for short, is a very large and the only public pediatric hospital. There's 320 beds and about 3,000 admissions per month, with a very high 10% mortality rate among those patients hospitalized. It's hard to be at the hospital and not recognize the sickle cell problem, but as the subsequent slides will demonstrate, there's likely even a larger burden of undiagnosed or unrecognized sickle cell disease. This pie chart represents outpatient visits at the hospital in 2010, I guess. And you see that the sort of light blue color that I highlight is over a quarter of the graph is hematology visits. This is 99.9% sickle cell patients, 18,000 outpatient hematology visits at this hospital, which is about 100 per day, typically staffed by 1 doctor and 2 nurses, 100 patients per day. This graph looks at inpatient admissions. This is reasons for inpatient admission, and you see that it doesn't really align that there's that many sickle cell patients seen in the outpatient setting, but sickle cell disease is only listed as the 8th most common indication for admission. This probably represents only pain crises and overt sickle cell complications, but the smaller arrows that I highlight, anemia, malaria, respiratory illness, meningitis, sickle cell disease is probably very overrepresented in these categories, but not quite recognized. This is similar to the general global health setting where these diagnoses are always listed on causes of child mortality, but sickle cell disease never quite is. So when we started over 2.5 years ago, the goal of the pilot phase was to be very careful and demonstrative. The burden of disease was kind of recognized, but not truly recognized. We wanted to demonstrate that burden of disease, and the best way to do that in an effective and meaningful way is by newborn screening. So the really primary goal of the first phase of the program was to start a newborn screening program carefully in Luanda. And newborn screening, as Russell mentioned, is not really commonplace across the African continent at all, and it's not clear whether even the process of newborn screening was feasible, from the collection of the blood to the processing of the laboratory samples to the finding and treatment of babies. And also, since each step of this program was to happen in the public realm, it was important to develop capacity at all levels, in the laboratory, at the maternity hospitals, in the clinic, with the lay public. And as the program succeeded in small steps, the plan was to expand this in phases over time very carefully. This demonstrates the process. The first step is testing the baby. It's done by heel stick, just as it would be done in Ohio or any other U.S. state. We started at one very large maternity hospital in Luanda and subsequently expanded, where currently there are 5 centers across Luanda that are testing babies. The samples are transported to a central newborn screening laboratory in Luanda at the public pediatric hospital. Screening is done by isoelectric focusing, usually quite quickly, usually within 1 week of specimen arrival. After babies are diagnosed with sickle cell disease by newborn screening, typically with the hemoglobin pattern of hemoglobin FS, attempt is made to contact the families typically by telephone. We'll talk a little more about that in a couple of slides. And then when infants are found, they're brought to our clinic usually by 6 or 8 weeks of age, where they would initiate treatment and families would receive education. So the collection and laboratory procedures really are not dissimilar to most U.S. states. Hemoglobin pattern is identified by isoelectric focusing. It's a little figure here on the right demonstrates the 3 bands that we saw 99.9% of the time. The far left pattern illustrates hemoglobin FAS pattern, which is consistent with sickle cell trait. The middle pattern is hemoglobin FA, which is normal baby, hemoglobin AA, normal hemoglobin pattern. And the right side, which is missing the middle band, which is hemoglobin A, is consistent with hemoglobin FS, the hemoglobin FS pattern, or sickle cell disease. We did try to add a subsequent step with capillary electrophoresis, but for many technical reasons, it was really demonstrated that this secondary step was not very effective in our setting. These are results from the first 2 years, the first 23 months of the program. The program started in middle of July 2011. These results represent through the end of June 2013. Over 36,000 babies were tested, and 1 in 66, or 1.5% of babies were demonstrated to have a pattern of hemoglobin FS, consistent with sickle cell anemia. And over 21% of infants had a pattern consistent with sickle cell trait, which is truly remarkable given the true lack of awareness in the country that 1 in 5 people probably have hemoglobin AS. No newborn screening program would be meaningful if there were not a closely associated treatment program or follow-up plan. And our plan was to return the babies to clinic by 2 or 4 months of age before the symptoms of sickle cell disease really manifested. And similar to as we do here in this country, the plan was to educate the parents, particularly about the meaning of the importance of symptoms such as fever and splenomegaly. At the beginning of the program, we actually provided pneumococcal vaccination as it was not available publicly with the support of Chevron, but now pneumococcal vaccine is available in Angola. We started penicillin prophylaxis. We provided a mosquito net to prevent malaria, and provided routine care every 3 months through the first year. So finding babies remains a challenge. Through the first 2 years of the program, we found 54% of those babies that had a pattern consistent with sickle cell anemia, which may not sound very high compared to the rates that we find in this country, but in that setting with the resources, and in comparison with similar retrieval rates for diseases such as HIV, that number is not too bad. The more remarkable number is that when we found babies, they almost always came back. There were a few deaths. There were 9 deaths over the first 2 years, which is less than even the infant mortality. In Angola, 9.8% of infants will die before they're 1 year of age. And of the infants in our pilot cohort who reached the age of 1, only 6.8% of them died. This has been demonstrated in other settings that general health care interventions may reduce mortality to rates even below national mortality rates. And so far, in the first 2 years, we've demonstrated this in Angola. The lack of finding babies is interesting and probably a result of a variety of factors, including a very overpopulated and poor city such as Luanda, where many families don't even have addresses and telephones are out of service. And Angola is one of the few countries in Africa which does not really have an organized community health care program. So it really helps to identify some gaps in the healthcare system that need to be worked on over time. As I said, there were only 9 deaths in the cohort, but each of the 9 deaths really was demonstrative. Aside from one infant who presented acutely and died in a car accident, all of the other 8 deaths were infants who had acute symptoms of sickle cell disease, fever, pallor, lethargy, and the parents, all of them, brought them to the emergency department as instructed, and that's really all we can ask of them. And the breakdown happened when they arrived at the emergency room. Many of these happen in the community, where awareness of the healthcare providers is quite low. Many of these infants presented with fever, received some Tylenol or non-antibiotics, anti-malarial treatment often, and were sent home. And by the time they got home, they were sick again with fever and often died before they could get back to the hospital. This again was demonstrative. It's important to know that the awareness is quite low, and it identifies areas in which we can improve. So over the first 2 years, we really demonstrated that we can do what we do here in the United States in Luanda. We did. The babies are tested at the maternity hospitals. The samples are brought to a central laboratory where they're processed. Babies are contacted. Families are brought to the clinic. They're educated. They receive penicillin, and they receive follow-up care. The next steps, such as hydroxyurea and other disease-modifying interventions have not yet occurred, but are certainly on the agenda. So this is Luanda. This is in a very unique pilot program. What about the rest of the country? Even before we arrived over 2.5 years ago, at HPDB there was a sickle cell clinic. At least there were some providers who knew about the disease. The director of the hospital, Dr. Bernardino, was a hematologist, and so he took very good care of that clinic where patients, for the most part, were receiving penicillin and basic care. But outside of Luanda, Luanda is only one of 18 other provinces. Each province probably has about 500,000 or 1 million people, and there's very few pediatricians in any of these provinces, and certainly no hematologists. And the knowledge about even the very basics of sickle cell disease is quite poor outside of the capital city. These are very rough estimates of the possible burden of sickle cell disease in the different provinces based on some population figures from some time ago. But it really just demonstrates that even though some of these provinces may be small, there's still hundreds to thousands of babies born every single year with sickle cell disease. And without public awareness, no newborn screening, and really no awareness among any healthcare provider, mortality in these settings is probably quite high. When you read about estimates of sickle cell mortality in sub-Saharan Africa, you see ranges from 50% under 5 mortality to 80 or 90% under 5 mortality. And if I were to make a guess, I would suggest that it's closer to probably 50 in a place like Luanda where there's some basic interventions. But in some of these remote provinces where there's really nothing available for these infants, and probably none of them are taking penicillin and none of them know anything about the disease, the mortality is probably quite high, approaching 80 or 90%. And another side note is that in addition to the thousands that are born with SS, there's tens, hundreds of, over 100,000 born with hemoglobin AS. These are people who will grow up and have babies in a couple of decades but are not aware of what their carrier status means. So one example is in the province of Cabinda, which is an exclave province in the north of Angola. The population is about 300 or 500,000. There's very few public health resources. Many families in Cabinda actually travel to the Congo or the Democratic Republic or the Republic of Congo for even basic medical care like vaccines or anything that require hospitalization. Our pilot program extended to Cabinda in late 2012. The picture at the top demonstrates one of the Baylor College of Medicine Global Health Corps physicians who are young pediatricians out of residency who spend a year or two in a remote setting to provide care and training. We had 2 of these doctors in Cabinda during the last year or two, and they were up there to develop the program in Cabinda. The focus was on newborn screening and developing some local capacity. The clinic up there opened their doors and put a little sign at the front of the pediatric outpatient building that there was a sickle cell clinic, and now there's over 200 children enrolled. In talking to these families and these children, it was very demonstrative of what's happening there. Really, none of these children were taking penicillin prophylaxis. Very few had pneumococcal immunization unless the families were traveling to the Congo. And the most interesting fact was that they were way over-transfused. Nearly every time they went to the emergency room, whether it was for a cough, for a rash, or for acute anemia, they got transfused no matter what. Many of these children, 2, 3, 4 years old, had too numerous transfusions to count. That was the most common answer when parents were asked, 50, 100 transfusions in the first couple years of life. And acute complications, acute and chronic complications, stroke, leg ulcers that were really just ignored. So these are more very rough estimates using our pilot data, but knowing that there's 800,000 or so births per year in Angola, we saw an incidence of 1.5% in Luanda, but it's probably a little lower through the rest of the country. So using a range of 1 to 1.5% incidence of SS disease, there's about 8,000 or 12,000 babies born every single year in Angola with hemoglobin SS disease. And again, with very conservative estimates, over 5,000 of these infants will probably die before they reach 5. And these are total invisible deaths. They'll never show up on the Angolan registry as deaths from sickle cell disease. They'll die from anemia or infection or other causes. And some other extrapolations, nearly half of the population of Angola, as is common in many African countries, are children. With improved survival, using this as an estimate and population estimates, as newborn screening is expanded and sickle cell awareness is improved, there could be over 100,000 children less than 15 years living in Angola with sickle cell disease. This really demonstrates the urgent need to start improving the awareness among healthcare workers and also improving access to disease-modifying therapy so as to not overwhelm the healthcare system. And one model that the country, the Ministry of Health, and I think other African countries seem to believe is that the only way to truly care for these children is by decentralizing care. There's no way you're going to have enough hematologists in Angola to treat 100,000 children, but you can certainly train basic healthcare workers, nurses, and doctors, people who are providing the frontline care about the diagnosis and the major complications. Currently in Angola, outside of the two that I described in Luanda and Cabinda, there's very few clinics and very few providers who really know enough about sickle cell disease to provide even the most basic care. The education in the medical school and the nursing school is also quite limited given this burden of disease. And so the ultimate model will really be to have a decentralized system where there are specialty clinics to deal with complications and complicated cases, but really the basic care, including penicillin and most of the emergency care, really should happen on the periphery. So there's a plan that's been initiated through the help of the Ware program and also with the help of the public health system to decentralize care, where we have this one large, busy clinic with some level of expertise at the pediatric hospital, but there's 5 or 7 million people in Luanda and maybe up to 10,000 children with sickle cell disease. The current clinic, which has 100 patients per day, 100 children per day, and 1 doctor and 2 nurses, could never provide adequate, complete care for these children. The need is to create outlying posts. And it's also very difficult for some families to make it to this clinic, whether for routine visits or for emergency care. The city isn't geographically huge, but the traffic is really horrendous, and it could take 3 hours and 5 taxis to get from their home to the clinic in the morning, and the same thing on the way back. This is an expense and time that is really difficult for many of these families. So the idea is that you would find teams of doctors, nurses, social workers, laboratory technicians who would come to the main pediatric hospital and spend a few weeks or a month and learn. And you can learn by osmosis just by being in a clinic that has 100 patients every day. And once these teams are trained, they can go back to their own communities and open their doors to start seeing patients for basic care. And these trained teams can become advocates for sickle cell disease in their areas and help to train their colleagues. Similarly, nationally, this is a huge need. Outside of Luanda and Cabinda, as I mentioned, there's really nothing for most of these patients. And again, mortality is very high. And before newborn screening has been successful in Luanda, but you can't even think about initiating newborn screening across the country without an associated care plan. So there's an urgent need to train people in each of these 18 provinces about basic sickle cell care and diagnosis, such that they can go back to their own provinces and start newborn screening, and they can identify babies at birth and treat them as they grow up. So changing gears a little bit, we haven't got too far into this realm, but you can't have a conversation about sickle cell disease in Africa without talking about sickle awareness and genetic counseling. 21% in our pilot newborn screening cohort have sickle cell anemia. When I've given talks in Angola, which is mostly full of healthcare professionals or students, nearly nobody knows what their sickle cell status is. And if nobody knows, then more babies are going to be born. You're never really going to reduce the burden of disease with newborn screening or even with hydroxyurea. The only way to reduce the burden of disease is by improving education of people and improving the genetic counseling concept. There's a pilot project that I'm supporting my colleague Bisalela Della Vera in Angola with, supported by the AAP's iCatch program, which is going to start soon, just in a couple of months. And the idea of this program is to go locally in Luanda every month to schools, mostly targeting adolescents, where you provide an hour or so didactic lecture about the very basics of sickle cell disease, the genetics, why it's important, how it's inherited, very basic things. And then, especially targeted towards this audience, have peers, volunteer peers who we train, who would spend time in a small session kind of talking about what it really means in a smaller session where the adolescents can ask questions and they can truly understand the meaning. And then everyone who comes to these, we're estimating maybe a couple or a few hundred per month, will be tested by a finger prick on a blood spot. The blood will be tested by IEF, and we'll return a sickle status card to them where it says you are hemoglobin AS with a little explanation of what that means. And hopefully they'll keep that and remember that when they make decisions about who their partner may be or if they have children in the future. And this again is a demonstration project such that hopefully the Angolan Ministry of Health and the various other ministries, the Ministry of Family and the Ministry of Education, may support in the future to help to increase the awareness and reduce the true burden of disease over time.
So we'll shift gears now to talk a little bit about hydroxyurea and what potential impact it could have in Angola. Patrick mentioned the high burden of disease and the fact that, ironically, if you can identify babies, keep them alive, put them into a clinic for care and treatment, then you, in some ways, increase the burden of disease by having more sick children. And so it becomes imperative to think about how can you add in a disease-modifying therapy, which currently is either transfusions or hydroxyurea. And there have been a number of discussions about the best and safest ways to introduce hydroxyurea, and so we'll give you our idea about how it might work in Angola. As many of you would know, it's a once-daily oral medication, so it's relatively convenient to use in a low-resource setting. It's also quite inexpensive, certainly by U.S. standards, and no effort has been made yet to really reduce the cost further for low-resource settings, but it approaches a utility and a cost that could be considered for a country like Angola. And there's now 30 years of evidence in developing countries, the U.S. and Europe, about the safety and efficacy for hydroxyurea, but almost nothing in low-resource settings. A few articles coming out now, but very little experience in Africa. And really the question is, should this be considered an ideal treatment option, but can it be used safely? Can we export what we think we know about it in the Western Hemisphere and bring that in and use dosing and monitoring regimens that may not be suitable for Angola? So we have designed a trial, acronym REACH, for realizing effectiveness across continents with hydroxyurea, that proposes to gather some important pilot data. It will be an open-label dose escalation trial of hydroxyurea for children in a few settings in Africa. And its objectives are fairly basic: feasibility, safety, and some early information on benefits. Feasibility would be assessed by visits, attendance, blood counts, medication adherence, safety, by cytopenias and toxicities, and benefits. Although it's not an efficacy trial, we'll gather some information on that. The study design would be at several locations to use a fixed dose. We'll start at a dose that's relatively modest, 15 to 20 milligrams per kilogram per day. If that turns out at an early safety analysis to have a high number of cytopenias, toxicities, then the dose would be lowered. But the hope would be that if that fixed dose were tolerated, then there could be a dose escalation, but we'll see whether that's actually feasible. And then a maintenance phase through a common termination date. So the subjects would be young, and they would be pretty much all comers with regard to clinical severity, except for having some clinical condition, chronic illness, severe malnutrition, that would preclude them from entering the study. But it's meant to be fairly inclusive to try to get generalizable knowledge about the safety in Africa. Now, if we're successful with this, then I think these pilot data will be critical to determine the feasibility and safety and dosing, and this information will be very useful to ministries of health and countries who desperately want to use a medicine that would be useful and affordable for their patients, but whether or not the dosing and monitoring will be suitable for them, time will tell. So back to the WHO, in the document that I alluded to earlier, that is worth reading because it lists some very fundamental guiding principles for how WHO would recommend sickle cell strategies be developed in Africa. And I think the efforts that were made during this pilot program and will be carried on by the Baylor College of Medicine and any other groups in sub-Saharan Africa try to adhere to this, and I think these are very important principles. Country ownership. It can't be that the program comes in and does the work. There has to be community participation, leadership, fairness. It has to be done with teams and teaching at the local level. There needs to be effectiveness, cost-effectiveness, and accessibility of interventions and services. Certainly the introduction of penicillin and pneumococcal vaccines is evidence that we've gathered here in the West and also has proven to be successful and effective there. Recent cost-effectiveness analysis that was reported at ASH for this program shows that it's very cost-effective too. There has to be an integrated intervention and prevention, a population-based approach. And really the key here is to gather data so that the ministries of health can start to develop a national health plan or a national strategy. Many countries in Africa have a malaria plan, have an HIV strategy, have a tuberculosis approach, but have nothing on sickle cell. Partnership, team building, coordination, capacity building is really, really important. And then something that we strive for but is sometimes not sure how successful would be cultural sensitivity and accountability. But all these are very important guiding principles to try to adhere to. Now, WHO also lists priority interventions in this document, and here we list 5 that are ongoing and are being addressed by the program and others. And then in the next slide, I'll show you some that are future state. So certainly advocacy for increased awareness, and Angola is now an active member of the Central African Network known as REDAC and participates in the Global Sickle Cell Disease Network. Partnerships, well, by its early formation with Chevron Corporation, international partnerships, Brazil and Portugal are very active in Angola. Early identification and screening, well, that's obvious. We've described the pilot program. Capacity building, Dr. Mcgann did not really say it explicitly, but all the work was done by Angolan nurses and technicians and social workers and physicians and nurses. It was entirely done with Angolan talent, and we really were struck by the high quality and commitment of our Angolan colleagues. And in order to do that at a national level, the education is a priority, and so these efforts will be important for the future. And then research promotion. It's one thing to do care and treatment, but it's another to really advance the field, and there are so many opportunities to do high-quality, effective implementation research, cost effectiveness, and so on. So we recognize that there's a great importance for research promotion. But priority interventions that may or may not be current state for Angola would be listed here. Genetic counseling for primary prevention, having a national program, having comprehensive health management for sickle cell patients of all ages, affordable medications, and sickle cell disease surveillance. And I'm aware of other countries in sub-Saharan Africa that are working on these at different states and stages. And so it really is an exciting time to be involved with the process because there's so much progress being made on this under-recognized problem. So as we look back on it and make observations and try to identify lessons learned, there's no question that these simple observations lead to important lessons. How staggeringly high the burden of sickle cell disease is indicates that newborn screening is mandatory and really universal newborn screening is needed. But there are many logistical challenges to the process, and that's why having a small pilot program with frequent monitoring and evaluation and assessment of what you're doing right and what you're not doing right is essential to improving. We were struck by the low general awareness of the genetics and sickle status, not only of the general public, but also the healthcare providers. And so a lot of training and education is needed. It's our opinion that access to hydroxyurea is necessary, but our knowledge and access now is very limited, and so there needs to be some introduction prospectively. And then many questions remain, so much research is needed. So in summary, we believe that sickle cell is a highly significant, under-addressed problem. The pilot program that was performed in Luanda documented some very important features, feasibility, effectiveness, and cost effectiveness. That there will be an important need for disease-modifying therapy, ideally with hydroxyurea, and large-scale efforts are needed to increase awareness among healthcare professionals and the public. So in summary, I want to again acknowledge the important contributions of the government of Angola, First Lady, Minister of Health, of Chevron Corporation in both the United States as well as in Africa, in Angola, the Baylor College of Medicine and its partners in the three-way partnership, and the important things that they're going to continue doing, even though Dr. Mcgann and my affiliation is now moved over to another institution. And I guess that concludes our part of the presentation, and we would be happy to answer any questions.
Thank you, Dr. Mcgann and Dr. Ware, for an excellent presentation. We're now going to open the lines for questions. For the audience, please remember to unmute your phone individually by pressing *6. If you have a question and you're on the webinar, you can raise your hand electronically, and I'll call on your names in the order that they're received. And we have this line until 3 o'clock, so we have roughly about 15 minutes for questions. Let's see. Our first question is from Nancy Green. She asks, did you do informed consent with the infant blood sampling? And also, did you contact families of babies with hemoglobin AS?
So the first question is whether or not informed consent was performed, and the answer is no. It was deemed by the Ministry of Health that this was a public health need, and just like in the United States, where informed consent is not required for newborn screening, it was not required there. With regard to trait?
So that's obviously an ultimate goal of the program, is to contact and inform the carriers, but our staff and resources were quite limited. And of the 36,000 babies that were tested, 6,000 or 7,000 had sickle cell trait, and we didn't have the resources to contact or identify those families yet. We focused our resources on finding the families who were affected by sickle cell disease.
Great, thank you. We have a question from Althea Grant. She asks, do you have an evaluation plan for the impact of the sickle cell trait education program?
We're still working on a lot of the logistics of that program. We certainly will plan to evaluate and document what we're doing, but the true plan and the details therein are still being formulated.
Great, thank you. I don't have any more questions on the webinar screen, but maybe there are a few individuals who have questions by phone. You can just go ahead and ask your questions at this time. Do we have any questions from anyone? Remember to unmute your phone by pressing *6.
Oh, this is Althea. I have an additional question. So it's you know, your slides were so impactful. I was really struck by the fact that there clearly is a missed opportunity around health education for providers. And I'm wondering if you have, you know, because a lot of the deaths could have been avoided. Do you have plans around developing provider education, like specific programs planned?
Yeah, that certainly was an important issue that we recognized and we raised with the National Health Ministry and the other authorities who help with education and training. And I don't know what's happening at this moment. I know that as I left Baylor a month ago, the plan was to continue with these educational efforts, and they remain on the radar screen. But it's very difficult to mobilize these resources in a meaningful way. But this is certainly being thought about by us, by Baylor, by the Ministry of Health. But it's very difficult to accomplish.
Thank you. And the other thing I was going to add, and I don't know if Dr. Henny-Frimpong is on, I was thinking about the trait and the carrier issue, and it's something we've talked about with regard to the program in Ghana, and that's something we're actively trying to develop a genetic counselor training program. And I think that would be an area where, collaboration would be really beneficial because this is going to be a universal problem. So we're trying to develop a curriculum around sickle cell education in general, but that could be adapted to carriers as well. Because one of the fears that I have, as people enter this space is that in a lot of countries this is a condition where you could potentially really stigmatize people. So as you expand and more people know their status, if there's not the appropriate education and counseling, it could also have negative effects.
That's a great point, and very well received, as there's obviously no genetic counseling in any capacity in Angola or no training program, but certainly utilizing the work that's going on in Ghana and that you're involved with would be great for Angola, whether even from my small-scale training program for adolescents. I'm eager to hear your thoughts and opinions offline about that, but it certainly is an important point.
Okay, and we have a question from Keisha Hampton. She writes, did you encounter any problems with parents refusing the test?
I wasn't at the bedside every time the test occurred, but I actually would find that it's quite the opposite, that the parents demand the test. In a country where healthcare resources and tests and medications are so limited, when a family hears about something being available, they want it. And so many times the nurses would be too busy or maybe didn't collect 100% of the babies. But as parents were aware of the test happening or saw advertisements or heard from their neighbors that the test occurred, it actually was probably the opposite, that they demanded it more than they denied it. I don't know of any cases when they actually denied it.
Great, thank you. We have another question from Tommy Thomas, who asks, does nutrition have any effect on the sickle cell patients in terms of the foods that they eat locally, and why is there such limited knowledge about sickle cell?
Nutrition is certainly a complicating factor for a variety of reasons. I found that since there's really no hydroxyurea available, there's many sort of strange nutrition practices where beets are one food that they thought maybe because they're red or have a number of vitamins would help their hemoglobin, and in some vitamin deficiency that may help, but it's not going to help for sickle cell disease. So nutrition certainly can cause more anemia for other vitamin deficiency reasons and malnutrition, but nutrition practices don't really change the course of the disease significantly in Angola.
Just to follow up on that, one of the important comorbidities that we're going to address in the REACH trial will be the role of malnutrition on the hydroxyurea response and the toxicities.
Thank you. Let me take one more question on the line, and then I have another question on the webinar. Go ahead to who was about to speak.
Yeah, I had two. Well, just one comment about the iCatch program that you're talking about, adolescent education. It seemed like that is really fraught with so much potential unintended consequences. If you tell people about their sickle trait status and don't give them any really thing that they can do about it, it seems like in some ways it's really fraught. I mean, you're not going to be able to provide them with genetic counseling. You're not going to be able to provide them with alternatives. Like, are you going to recommend, some areas would recommend abortion if you find that you have a child who has sickle cell disease. I mean, things like that. It just feels like you're giving people knowledge, but not really giving them adequate knowledge to do something preventive for themselves and their potential children, or it just feels a little bit fraught. Anyway, I'll just bring that up. And the other question I just wanted to kind of ask was the reason for so much transfusion. It seems so interesting that there's so little level of information and knowledge about sickle cell disease, and perhaps that's why there's so many transfusions, because they just see an anemic child who is sick, but also they have the technology to provide so many transfusions, you're saying in the hundreds, when so many aspects of medical care are so limited. I just was perplexed by that.
And thanks for the great points and questions. Maybe I wasn't entirely clear about the ICATCH program, but the goal is to target adolescents before they choose their partner and who they may have babies with, and genetic counseling will be a part of it. Kind of pre-genetic counseling, we'll tell them all about what it may mean if they get tested, and then when we return with their result, there will be genetic counseling by us, or we'll essentially train, either we'll do it directly, Visalella, or members of our team, so that they know, they're 15 years old and they know that they have AS and what that means, and when they think about who they may have children with, they will choose people who don't. So,
that's okay. Usually people don't choose their partners that way, but okay.
Well, I don't think. Okay.
Yeah. Go ahead. I'm sorry.
And the second question about transfusion. So in Cabinda, I think that's a very unique situation. Typically, the way that transfusion works in Angola is that you have to either find your direct donor, like in the moment, like you call your uncle or friend or neighbor and they come and donate blood, or you have to find someone to replace the blood that you use, so as not to diminish the blood supply. So I can't understand entirely why they are so transfusion heavy in Cabinda, or they're just really good at finding neighbors who can transfuse blood. But for the rest of the country, even at the big pediatric hospital, transfusion is difficult, as you would expect. I think Cabinda is a unique population that I can't entirely explain, but through simple education, we can certainly decrease that transfusion burden unnecessarily.
But they have the technology for matching blood and providing transfusions.
They have basic technologies for that, and most of the blood is screened. In Cabinda, actually, their blood bank is supported by Chevron also, such that all blood is tested for HIV and hepatitis and such.
Thank you.
All right, we have a question from Scott Gross. He says, could you please talk about the implications of frequent transfusions for iron overload? Additionally, could hospitals use the savings from doing fewer transfusions to pay for preventative care?
That's a great point by Scott. So, as most of you probably know, overtransfusion, so these patients in Cabinda that I talk about, there are 3 or 4 or even older who survived the tumultuous first couple of years and now are overtransfused, will probably die of iron overload before they may even die of sickle cell symptoms. It's a unique issue in Africa, and iron chelation is certainly expensive, but I think that focusing on preventing life-threatening complications and utilizing transfusions when they're necessary during splenic sequestration or malaria is really the focus. So just more health education, because certainly, at least in Cabinda where I talk about it, it's a great waste of health resources to use all that energy on blood, where expenditures could be used for other things like penicillin and vaccinations.
Excellent. Do we have any other questions on the line? Last opportunity. Okay, well, our time is just about up. The next webinar will take place on Thursday, February 27th on the history of sickle cell disease by Dr. Todd Savitt. If you have any questions about the webinar, please feel free to contact me at spope@cdc.gov. The recording of the webinars are made available on scinfo.org under the webinars toolbar. Dr. Mcgann and Dr. Ware, thank you again for participating. And again, contact me if you have any questions. Thank you. Have a great afternoon.